Good afternoon, everybody. Today I am going to discuss about polycythemia, which is a blood disorder due to excessive blood cells. We will discuss about the causes, the types, the symptoms, and also the management of this deadly disease. So, first of all, we have to know what is polycythemia. Polycythemia is characterized by an abnormal increase in red blood cells. So the normally whatever the red blood cells present in our body, that is 4 to 4.5 million per cubic mm of blood. If it is increases above the normal range, then hemoglobin increases and hematocrit means PCV value also increases. Then the blood becomes thicker because the density of the blood increases, its viscosity of the blood increases, and this problem, blood disorder, is called polycythemia. You can see that written here, while normal hematocrit ranges 38 to 54% in men and 36 to 46% in women, polycythemia patient can have values exceeding 60%. So you can think that how much amount of or the volume of red blood cell is present in the blood. Now, regarding the classification of polycythemia, there are basic four classifications. So, number one is primary polycythemia, which is known as polycythemia vera. Now, it is very rare and it is due to acquired genetic mutation. Means when there is a specific gene which are dedicated for the production of certain cells, when it is mutated, then the bone marrow stem cells leads to autonomous overproduction of red blood cells. So what are the stem cells? Stem cells are those cells from where the different cell line originates. Now it is independent of erythropoietin or EPO. It is a protein which is originated from the kidney, and it helps in the erythropoiesis. And now if it is a question of gene mutation, then we should know which gene is mutated. The name is JAK2 gene mutation in over 95% of cases. So this is primary polycythemia or polycythemia vera. Now, in case of the secondary polycythemia, it is due to the physiologic response to tissue hypoxia or abnormal EPO production. And there are different common causes like COPD, sleep apnea, high altitude residents, etc. So most of them are comes within the habit. So it is due to the tissue hypoxia or abnormal EPO production. EPO means erythropoietin. Next, relative polycythemia. Now, what is relative polycythemia? Normal red cell mass but reduced plasma volume. Normal red cell mass means the amount of the red cell is normal, but the plasma volume is reduced, so the viscosity increases. Appearance of polycythemia, often caused by dehydration when there is less amount of water in the body. Diuretics, enough water is released out from the body, burn or stress induced fluid shift. So when there is less amount of water in the body, plasma volume decreases and the uh, red blood cells are aggregated in such a way that it looks like there is a high viscosity and density, and it is called relative polycythemia. And the last one is stress polycythemia or Gais-Bok syndrome. Now, what is that? Chronic stress-induced reduction in plasma volume with normal RBC mass. So when there is stress-induced reduction, like when a person is hypertensive, when a person is overweight or middle-aged men, so they are much more prone of hydration, less hydration. Less hydration means less amount of plasma volume. If due to some mental problem there is less amount of intake of water, then comes the stress polycythemia or the Gais-Bok syndrome. So these are the four different types of polycythemia with four different type of reasons. Primary polycythemia, acquired genetic mutation. Secondary polycythemia, tissue hypoxia or abnormal EPO production. Relative polycythemia, less hydration. Stress polycythemia, reduction in the plasma volume due to mental stress. Now we will take a look on polycythemia vera in depth. So it is a chronic myeloproliferative neoplasm. Myeloproliferative means when there is multiple proliferation in the cell. Cell is growing very fast. The incidence is approximately 2 to 3 cases in 1 lakh person in year, and median age 60. This the mutation of this gene JAK2V617F is present approximately in 95% of the cases, causing consecutive activation of this pathway and unregulated cell proliferation. Beyond elevated RBC, 50% of patients exhibit increased white blood cell and platelet also, reflecting the stem cell origin of the disorder. So not only the RBC is elevated, but 50% of patients show the increased WBC and platelet also. That means when there is a problem in the bone marrow stem cell, which gives rise to different types of cell line. So when there is malfunction of bone marrow stem cell, though there will be huge amount of RBC along with the other cells will be also produced in higher range. So this is the primary polycythemia vera. The causes mutation of JAK2V617F gene. The secondary polycythemia is due to the body's response to low oxygen. So number one reason is tissue hypoxia. What is that? Chronic hypoxia from conditions like COPD, sleep apnea, congenital heart disease and high altitude living reduces oxygen saturation. So less amount of oxygen is inside the body. That might be also due to smoking induced carboxyhemoglobin formation. Means whatever the reason is, less amount of oxygen is inside the body. This is called tissue hypoxia. This also causes the functional anemia. Now EPO production. Kidney detect low oxygen and increase the erythropoietin production. This is the normal thing. Kidney detect the low oxygen and increases the erythropoietin production so that excess amount of or increased amount of RBC can be produced. But in rare cases when there is tumor or the cell carcinoma, it autonomously produces the EPO, means it doesn't wait that whether the oxygen level is low or not. And 4% of the secondary polycythemia cases. Next, RBC proliferation. Elevated EPO stimulates the bone marrow to increase the red cell production. So it is the result, and RBC proliferation is the result, and EPO, we can say RBC proliferation is the result and EPO production is the reason. So secondary polycythemia can be caused by these reasons: tissue hypoxia, then EPO production, and ultimate the result is RBC proliferation. What are the clinical signs and symptoms? What patient experience actually? So there are two types of symptoms. Number one is hyperviscosity symptoms. Another one is hypervolemia symptoms. So you should remember very crucially that there are two symptoms: hyperviscosity and hypervolemia. So regarding the hyperviscosity syndrome, there will be, as the viscosity is increased, then there will be headache and dizziness. Then visual disturbances will be there because enough RBC is not going there. There will be angina or the chest pain. That means it will be a burden on the cardiovascular system. Thrombosis, there will be blood clot, there will be shortness of breath. So these are the hyperviscosity symptoms. Now what are the hypervolemic symptoms? Plethora. What is plethora? Ruddy completion. You can see in the face of this patient some patches of red patches are here. This is called plethora. Next, aquagenic pruritus means itching after the bathing. Then tinnitus and hearing problems, person cannot hear properly or there is a buzzing sound while hearing. Headache and confusion as because the enough oxygen is not going to the brain. And hypertension because of the viscosity, increased viscosity of the blood. How this polycythemia can be diagnosed? Number one, initial blood work. Complete blood count showing elevated RBC count, hemoglobin count, and hematocrit. So three things we have to take into account: RBC count, then hemoglobin value, and then hematocrit value. If all are increased, then a person is suffering from polycythemia. Now, what is differential? This is initial blood work. What is differential testing? Erythropoietin level. We have to look for the erythropoietin level. If it is hiked, then in most of the cases, there is polycythemia. Next, bone marrow biopsy. Whether the stem cells of the bone marrow is working properly or not. It shows hypercellularity with transient proliferation of primary polycythemia. Okay. Now, secondary cause investigation, oxygen saturation. So there are the four steps for diagnosing polycythemia. Number one is you have to go for the initial blood work where you have to do the CBC, complete blood count, which will tell whether the RBC count is high, the hemoglobin is high, or the hematocrit or PCB value is high. Then come for differential testing where we will see that whether the erythropoietin level is normal or higher. Next part coming the bone marrow biopsy where there will be hypercellularity in the bone marrow. Lastly, the oxygen saturation we have to confirm. Now, what are the management strategies from phlebotomy to medication? So, what is the first line of treatment? First line of treatment that is phlebotomy. Phlebotomy means removal of 300 to 500 ml of blood every 2 to 3 days, so that the volume of the blood will be decreased. And what will be the criteria for removal of blood? Hematocrit should reach less than 45% in men and less than 42% in women. So this is phlebotomy, management through phlebotomy. Another one is low dose aspirin, 81 to 100 milligram, reduces thrombotic complications. Thrombotic complications means accumulation of the blood or the clotting of the blood within the blood vessels. Next, hydration. Critical for relief polycythemia and adjunctive for all types. It is true for the secondary polycythemia. And also for the relative polycythemia. Then addressing for the underlying causes, whether there is a habit of smoking, it should be ceased, oxygen therapy if needed, surgical removal if needed. So these are the supportive. Then cryoreductive therapy. What is that? Hydroxyurea, first line of treatment for the patient greater than 60. Myelosuppressive agent. Interferon alpha to reduce which induces the molecular remission. It is for the younger patient, and the previous one for the patient greater than 60 years. So these are the other medications which are used for the as the management strategy for the polycythemia. Risk and complications if untreated. If the person is ignored, then what will happen? Number one is high chance of having death. Untreated polycythemia vera has 50% mortality within 18 months. 50% mortality within 18 months. Next, there will be some transformation. Okay, then there will be major thrombosis, means accumulation of blood into the coronary artery, cerebral artery, hepatic artery, peripheral vessels. Then microvascular complications. Blood flow will be hampered. Quality of the life impact. A person will not feel free in the daily life activities. So, what are the key takeaways? What we learned from this video, that polycythemia represents a spectrum of disorders with excess RBC. Next, distinguish between primary, secondary, and relative forms. Hyperviscosity symptoms. Regular monitoring is very important. And when to seek help, when we will go to the doctor. If there is persistent headache and dizziness, for a long period of time, if a person is suffering from these two problems, should consult the doctor. If there is unusual redness in the skin, itching after the warm showers, then unexpected explained fatigue or shortness of breath, burning pain in the hands and feet. So these are all indications that a person should go to the doctor to consult about if the person is suffering from polycythemia or not. So do like, share and subscribe my videos and my channel, which is eduhub.2m. Keep in touch for get the notification of regularly updated new videos related to medical and paramedical subjects. And if you have doubts or you want to know more about the topic, feel free to comment. If you like the video, then also you can comment. If you don't like the video, then also you can comment. You are free to write anything in the comment related to the video. If you have any question, please do that to me. I will be happy to give the answers. Thank you for your patient listening. Be with me. Thank you.